Some time ago, I made this video that said, hey, do you think E&M coding kind of sucks? Well, E&M coding has changed a lot since then, so it's really time to do an updated video series about why evaluation and management coding still sucks. So in my previous videos, we talked about scoring evaluation and management based off of the history, the exam, and the medical decision making. That is how evaluation and management has been scored since the scoring system was developed in 1995, and then it was revised in 1997 to develop different exams. So we've been working with those 95 and 97 guidelines for a long time. But then some time ago, Medicare came in with their Patients Over Paperwork plan. Patients Over Paperwork was Medicare's supposed initiative to help reduce the amount of paperwork for physicians and healthcare workers so that they could focus on patient care. Because the way we score evaluation and management was so outdated, of course, that was one of their big targets that they said, oh, we're going to improve, we're going to make it easier to not have to do as much paperwork for evaluation and management levels to be scored. In the previous scoring methods that we had in the 95 and 97 guidelines, technically you could hit this high level of service just by doing a high level of history and just by doing a high level exam, or at least documenting that there was a high level of history and a high level of examination done and collected and documented. Because providers got so efficient with electronic medical records, they had developed all kinds of templates and check systems that they could just go check, and do a complete history and check, and do a complete exam. And I even heard physicians say, oh, well, I need to have this complete exam. I need to have this complete history for billing purposes. Entirely not true. The provider needed to perform whatever the medically appropriate history and exam is, document that, and then bill the appropriate level of service, not just click all kinds of things so that we can bill higher. Initially, one of Medicare's solutions for this was they were going to collapse payments for office visits. They were going to have basically 3 levels instead of 5, like a low, a moderate, and a high. It did not go over well. Physicians were not happy. Administrators were not happy. A lot of provider feedback I heard was, well, if they're just going to pay me the same for levels 2 through 4, I'm just going to bill level 5s all the time. So in steps the AMA with like the steel chair, just beats the hell out of that and comes up with an entirely new way to score evaluation and management services. I mean, they dictate CPT, they can rewrite the rules, and technically speaking, how we score evaluation and management services in 95, the 97 guidelines, those were developed by CMS. There was no reference to these scoring guidelines in the CPT manual. So in a way, it was kind of cool to start seeing official guidelines written in the CPT book by the AMA. So we all held our breath, and with a few exceptions, CMS did say they would accept the AMA's way of scoring out E&M services, which would now be heavily based off of medical decision making because of how easy it was to just click through the exam and history. And really, medical decision making does help kind of drive that medical necessity component, which we'll talk more about medical necessity. Now, this was a huge change to go from having all of these little factors that calculate into the history and all of these little factors that calculate into the exam and all the little factors that go into medical decision making, and then all of that going into a level of service, and then changing that and saying, well, now we just have all these factors that go into medical decision making, and that translates into the level of service or time. So what the AMA did is they only made the new scoring method effective in 2021 for office and outpatient visits. Our 99201 through 99215 codes, new and established office patient visits. So what that does is it allowed us time to kind of work through some cases, perfect some things before the AMA then went and switched that methodology for the remainder of evaluation and management services. Then January 1 of 2023, the AMA converted all of the other evaluation and management service codes that were scored on history, exam, and medical decision making to now just the medical decision making or time concepts. The one exception is emergency department visits, and that's because emergency department visits are so complex. There's such fragmented time. It's so chaotic. It's hard to keep track of any kind of time concepts in the emergency department setting. So they are just based off of medical decision making. There's no time concept for the emergency department. So this is a lot of information, and I'm going to break it down into different videos so that we have a new playlist of how to score evaluation and management, and we can take it one step at a time. So what is an evaluation and management service? If you've ever watched any of those medical drama series like House, where the physician goes in and has that conversation with the patient and they diagnose what's going on with them or they ask them lots of questions, that's what an E&M service is. It's that conversation between a provider and a patient where they're asking them about their situation or they're counseling them, they're talking about their treatment plan. They're not actually doing a procedure like an injection or like a biopsy of anything, although sometimes that does happen at the same time as an evaluation and management service. But that E&M service is really that conversation between the provider and the patient and evaluating any potential problems or risks they might face and treating that problem or potential problem. In CPT, they're in the 90,000 series, but they actually are at the beginning of the book, and that's because they are the most billed, most used services, so they put them at the front not to confuse you for not being in numerical order, but because they're just so heavily used for ease, they just put them in the front. There's lots of different categories of evaluation and management services. Most of them are based on things like location. If the patient is admitted to the hospital, they're inpatient, or they're just in observation. If they're in an office, if they're in a nursing facility. There's also evaluation and management services for things like your annual physical well exam. These are actually all of the different categories of evaluation and management services that you will find in that section of CPT. But not all of them are scored. And when I say scored, we have different levels of service. So for example, an office visit might have 5 different levels. The more complex, the more work that is done on that patient, the higher that level might be. And the higher the level, it means there's a higher payment attached to it. So a provider might not get paid as much for a patient that's coming in with a urinary tract infection versus someone who has multiple complex medical conditions that they're trying to manage. But not all evaluation and management services are scored out and calculated based off of medical decision-making or time. There are some services like advanced care planning, which aren't scored based off of MDM, they're scored on other factors. Now in the past with E&M, since we had these 95 and 97 guidelines, we had different score sheets that we would use to basically calculate out the level of service. This one here is genitourinary, this one's neurology, this one's ears, nose, throat. Then we would have some that are kind of for general use, and I once heard them referred to as Dungeons and Dragons score sheets, which is kind of appropriate. For the 95 and 97 guidelines, we did have manuals that we used that were given by CMS on how different things are scored, what calculates for what, and we have that now with the AMA for the new scoring methodology, which is, I don't know, seems like a lot of paperwork to me. The AMA did provide a new score sheet for office and outpatient services. There is basically the same thing on the CPT book on pages 8 and 9 of the 2023 version. But at least as of the date that I'm recording this, the AMA hasn't given 2023 specific score sheets. I have some from NAMUS, which is an auditing association. I will link them below because I really do like these. The problem with the score sheets is you are not allowed to take them for the CPC exam. There are some other medical coding exams where you can take score sheets with you in person, or they will provide them for you through some sort of document through the online exams. But basically now, instead of having all of these different things and then having a level of history and all these different things, and that calculates the level of exam and all these different things that calculate the medical decision making, now we just have medical decision making. But medical decision making has gotten a little bit more involved, and we've clarified a lot of definitions and things surrounding it. There are 3 elements to medical decision making. The first is the number and complexity of problems addressed. Second is the amount and or complexity of data to be reviewed and analyzed. Third is the risk of complications and or morbidity or mortality of patient management. In order to hit a certain level of service, you need to have 2 of the components that would meet that level. We'll talk more about how this all factors together. We also have medical necessity, which is the overarching criterion for selection of a level of service. That means it has to be clinically appropriate for all of these things to have been done. For example, test results can often be given over the phone, so there's no medically necessary reason to drag a patient into the office just to tell them that their lab results were normal. It's not medically necessary to bill that patient for something that could have been done over the phone. So over the next few videos, I'm going to break down each of these different sections of evaluation and management. We're going to look at them. We're going to go over some case studies. We're going to look at the time components. We're going to bring it all together with some score sheets, and hopefully that helps you understand some of these new guidelines that we have, the ones that were effective for office visits on January 1st of 2021, and the ones that were effective January 1st of 2023 for all other E&M services. Keep in mind though, for example, if you're coding a hospital inpatient stay and it's prior to those guidelines being implemented, they go based off the old guidelines. They still go on history exam, medical decision making. So I'm still keeping those old videos up. So make sure that you are subscribed to this channel and then that you have hit the notification bell so that you can get alerts when I am posting these new videos, and get your CPT book ready, your pencils ready, your notes ready, because I'm going to try to do my best to demystify evaluation and management coding and make it as simple as I can for you. This is very complex and it takes most coders a while to really master evaluation and management coding. So I will see you guys in the next video, but until then, just keep on coding on.